Good morning. My immense gratitude to Vesomag for this invitation and for conceiving and executing this symposium. I'm fairly certain most of you are sleep deprived. Our rooms were strategically located under a nightclub last night, and youngsters were dancing away with a kind of energy that only they can summon. But I assure you my presentation with all the laden evidence is going to serve as a remedy for your sleep deprivation and put you to sleep. So it's a fairly dry topic, but let's see what we can do with this. What's the evidence for DCBs in the BTK, in the below the knee segment? And let's begin with an axiomatic self-evident truth, which is that you can't have CLTI without infragenicular or tibiopedal involvement. And the pattern, therefore, of atherosclerosis that we're concerned with is the kind that leads to CLTI, which looks like something like this. And so we're dealing with diabetic patients, elderly, with numerous other comorbidities, so it's a bad set to have. And in these kind of patients, what exactly is the kind of tibiopedal disease that you're dealing with? Remember, diabetics, heart disease, CKD, and so on. What kind of disease are you seeing in this common cohort of CLTI? You are seeing all occlusions, long ones, and usually in more than one tibials. The other thing to remember is that CLTI may be a terminal event. This is another truism that we must remember, and if best CLI data can show us something, it is that even if it isn't a terminal event, these patients are going to be dreadful risks. So this is the third truism that I wish to emphasize, and this is something we strongly believe in, which is that the management of CLTI is not about long-term patency. What you need is perfusion for roughly 200 days for wound healing and limb salvage. And this is encompassed by this wonderful phrase which is called situational perfusion enhancement, which means that if you have a wound, the oxygen demand of that wound is very high. Once it heals, even if the artery that you've opened up goes down, it returns to its baseline oxygen demand and usually doesn't recur. So we start this presentation with a fundamental question, which is that can POBA below the knee give you that situational perfusion enhancement? This is a systematic review and meta-analysis, 52 studies, roughly 6,800 patients. This is by Jihad Mustafa. And it showed that the pooled one-year patency after plain old balloon angioplasty was about 60 to 70%, and the one-year limb salvage rate was roughly about 85 to 86%. So you're safely crossing over that 200-day perfusion limit if you're doing a plain old balloon angioplasty. This is what matters. This is what you start with. And in this meta-analysis, the reintervention rates were about 18%. The other thing to remember is that even if you do manage to open up these below-the-knee segment vessels, in many instances, your best interventions may not salvage the limbs, and that's because of the scourge of small arterial disease. And recognition of small arterial disease has established a completely new scenario for CLTI. And it's now believed that MAC, or medial arterial calcinosis, is a reproducible and a powerful predictor of small arterial disease. It's easy to predict what the outcome is going to be just with an X-ray of the foot and a MAC score. What the MAC score is outside the purview of this presentation, but remember that. I mean, that's an information to be parked somewhere in the head. So SAD and MAC scores are very powerful predictors of the fate of CLTI patients. Part of SAD is an incomplete pedal arch. The pedal arch describes the connection between the anterior and the posterior circulation of the foot. And this very elegant 2017 paper from Florence brilliantly illustrates that it's the pedal arch patency and not direct angiosome revascularization that predicts the outcomes in CLTI, particularly in diabetics. So even the GVG guidelines now will ask you to factor in the status of the pedal arch. Completeness of the arch has a direct association with wound healing and limb salvage. Now, the reason I'm giving you such a long spiel and such a long prefatory exposition on this in a symposium on DCBs is because none of the trials involving DCBs and BTK lesions acknowledge this, any of what I just said, or factor in any of these complexities. Now, I wasn't there, unfortunately, for Dr. Devendra's presentation yesterday, but the history of drug-eluting technologies, particularly below the knee, counterintuitively starts off with drug-eluting stents. So drug-eluting stents came first, and they were largely limus-based, not largely, entirely limus-based, and then drug-coated balloon technology happens later. You would think that DCBs come first and DES comes later, but it happens in the reverse way. Drug-eluting stents come first, and our learning from drug-eluting stents was as follows, and in animal studies, that vascular smooth muscle cells start to hyperproliferate within 24 hours. So you need a large dose of the drug to immediately be conveyed to the artery. And what you need is a sustained drug for 30, 60, possibly even 90 days. And this is critical because this is the duration during which restenosis is going to have the highest chance. So what you need is a controlled release. Controlled release of the drug balances the need to inhibit these proliferating smooth muscle cells, but at the same time, it allows the intima to grow, the endothelial cells to grow, reducing the risk of late complications such as thrombosis. And these are some of the early trials in the early 2000s of the drug-eluting stents, which came before drug-coated balloons in the below-the-knee segment. And you can see with that, with the figures on the extreme right, that they were very promising studies. All of them are, not one of them is against drug-eluting stents below the knee. But the trouble is that if you were to pay attention to the fine print, these were lesion lengths in the range of about 30 millimeters, which is not typically the lesion lengths we treat, as has been established by various speakers, in the below-the-knee segment. Now, the other thing that I don't think has been adequately spoken about, and it's only appropriate that in a symposium that's dedicated to drug-eluting technologies, that we take a moment to pause and reflect on the word elute, its meaning, its implications, and its kind of understated elegance. The word has a Latin root. It means wash out. It is a term that started off in chromatography, which necessitated that there's a gradual release of the substance into the neighboring structure. And therefore, when we're using the word elute or eluting, there has to be a gradual washout or a gradual release. And therefore, in my view, my submission is that I don't think we should be conflating DCB and DEB. There's no such thing as DEB, except one, and we'll talk about it, because there isn't a balloon that gives you slow, controlled release. It's a one-time delivery of a payload into the vessel. So I think we should always refer to this as drug-coated and not use them exchangeably or fungibly. Now, why are below-the-knee lesions different? This is a very interesting study. Peripheral arteries from 95 patients following amputations. So there's about 121 amputation specimens in 95 patients were examined. And the pathological characteristics were separately recorded for the femoral, popliteal, and infrapopliteal arteries. And what you find is that in the femoral and popliteal segment, above the knee, there were atherosclerotic plaques. But what you had below the knee, suddenly it becomes medial calcification. And it's I don't have a pointer, but it's exactly the middle picture in the slide. The two arrows point to the gray zone, which is medial calcification. The other thing that this study reveals is that there is luminal thrombosis in the tibial vessels. Remember, these are 125 amputation specimens that had to be amputated for CLTI, and they're doing studies and sectioning of the vessels to see what these vessels reveal. So first, there's a significant medial calcification, not that much of atherosclerotic plaque burden. It's counterintuitive, but that's what the study shows. And secondly, there's luminal thrombosis, as some of these slides will, some of these pictures will show you. Now, the reason this is important is because, and this is the peculiarity of the BTK segment, that lipid, calcium, and thrombus are diffusion barriers for the drug to get into the artery. And so you have to ask yourself the question, what kind of vessel prep is possible in the BTK segment before you blow it up with the DCB? So again, data from that study, if you were to pay attention to the red marked areas, almost 70% of the BTK arteries have medial calcification, as opposed to a completely low figure in above the knee vessels. And in almost 50% of these specimens where there was medial calcification, the calcification involved more than 50% of the circumference of the artery. And almost 70% of the BTK arteries in this study were found to have some kind of thrombus of some age, in addition to calcification and some atherosclerotic plaque. So that is the other information we need to park inside our heads before we try and analyze data on the BTK segment. And before we evaluate the evidence, we should also consider some of the endpoints that we are discussing and when we are specifically speaking about outcomes. So one is binary restenosis. This word is bandied about so many times. The term binary refers to a simple yes or no outcome. So binary restenosis means whether restenosis occurred or not at a predetermined threshold. You determine that threshold, 6 months, 12 months, whatever. Was there restenosis? Percentage of restenosis is not relevant. So a lot of these studies will throw figures at you which will say binary restenosis, but evaluate that it's not a clinical parameter. It is a purely angiographic parameter. You do an angiogram after 6 months or 12 months, and then you decide whether restenosis happened or not. The other is late lumen loss. So you started with a lumen of whatever, 3 millimeters, and by how many millimeters did you lose that lumen at a predetermined interval? Again, this is an angiographic parameter, nothing to do with clinical symptoms, and it's calculated in millimeters. So this is the second endpoint that is thrown at you. The third is obviously target lesion revascularization or clinically driven target lesion revascularization. In my view, this is the most important thing because we've understood the complexity of BTK lesions. The patient came to you for a clinical symptom and seeks a reintervention. And if you were to do it, that is CDTLR. As opposed to, you do an angiogram, you find something, you treat it, the oculostenotic reflex. Now, once we've understood that, so we must ask, without prejudice or preconception, to what destination does the evidence compel us to go? And before I start that, I'm going to throw this at you, and this is largely because I received this gyan a couple of months ago from my wife, who's more invested in research. We must always look at the p-value. And I'm going to show you the studies, and you'll realize why this is important. Now, I had no idea up to, till a couple of months back, why a p-value of 0.05 is taken as a marker of significance. First of all, what p less than 0.05 means is that there's a 5% chance that the observed result could happen by random chance. So if you were to just flip a coin 100 times, if you were to get a desired outcome that is less than 5% chance, that means that this is not governed by chance. It is governed by your intervention. I'm doing something while flipping the coin, which is going to determine the outcome rather than by random chance. And the particular bit of gyan that I realized was that why is this arbitrary? It's a completely arbitrary cutoff. Why can it not be 0.03, 0.01? It is because the 5% chance comes from the two tail ends of the bell curve. You'll see 2.5% on the left and 2.5% on the right. What lies in the middle is normal occurrence. The outliers is what are governed by chance, and therefore you add 2.5 and 2.5, you get a 5% chance of a random occurrence, and that's why p less than 0.05 is considered clinically significant in biostatistics. Armed with this information, let's look at the evidence. And a lot of this is what Dr. Edward Choke and many others have shown you, but let's scrutinize this information. This is the first prospective randomized controlled trial that was carried out with involving DCBs in the below the knee segment. It's called DEBate BTK. And you find that the results are encouraging. There were about 132 participants. And again, what are the outcome parameters? Binary restenosis rates, which are better. Target lesion revascularization, not clinically driven, remember, which is better. But no significant differences in major amputation rates. So you've got two excellent parameters on angiograms, but made no difference to limb salvage. Okay, this is bandied about as the most successful BTK DCB trial. How to interpret it? Up to you. Next, this happens. So, DEBate BTK was in 2013. Next, this happens. This is the IMPACT DEEP trial, 12-month results, 358 participants. No significant difference in CDTLR, late lumen loss, or 1-year binary restenosis rate, all angiographic parameters. Increased major amputation rates in the DCB arm compared to that of the PT arm. But look at the p-value. It's 0.08. It is not less than 0.05. So this looks bad numerically, but is not statistically significant. But in view of this, the balloons were called back, as we know. We move along the timeline, 2015. This is the Biotronics first-in-man study using the Lux DCB. 71 participants, not very impressive. None of the primary endpoints were met. So see where this is going. This is not looking promising at all. The best trial, DEBate BTK, just numbers thrown at you, no difference to humans, okay? No difference to your patients. Again, this one, so none of the primary endpoints were met. And then this is dropped. The Katsanos meta-analysis and systematic review, this was published in the Journal of the American Heart Association in December of 2018, and it investigates the long-term safety in DCBs. Now, 28 randomized controlled trials, roughly 4,700 patients, and remember, this is across the board. This is not just BTK, this is SFA, popliteal BTK. But 89% of these studied were done for intermittent claudication. All right? What did it show? At 1 year, the all-cause mortality is the same, no difference. But as you track these patients along the natural course of their disease, at 2 years, there is a 7.2% mortality for drug-coated balloons versus a 3.8% mortality for non-drug-coated balloons. At 5 years, the mortality almost doubles to 14% for drug-coated devices versus 8% for non-drug-coated devices. All right? So this development, the Katsanos meta-analysis, very dramatically repositions at least paclitaxel devices, demoting them from the pedestal of kind of heroism on which they were placed to the ranks of the villainous in the narrative of drug-coated technologies and vascular innovation. The other thing that the Katsanos meta-analysis revealed was that higher doses of paclitaxel were linked to higher risk of death. So there is a predetermined dose per millimeter of the balloon, coated on the balloon. And IMPACT DEEP has about 3.5, I think Lutonix has 2, these are micrograms per millimeter, 3.5 versus 2. So the ones that used higher doses were linked to a higher risk of death. That's the other thing that the meta-analysis revealed. it dropped a bomb. But in the meanwhile, people didn't stop. I mean, there was this other trial that happened with Lutonix. This is from 2019, 442 participants. And like other trials, this one also does not meet the primary endpoints. As a saving grace, it establishes the non-inferiority. Now you're speaking of non-inferiority of drug-coated balloons below the knee compared to POBA. In response to Katsanos, Zeller et al. Bring this in, which is the 5-year outcomes of the IMPACT DEEP. Remember, not impressive study in the first place, which established that numerically there were higher amputation rates, and a 5-year follow-up reveals the following, that numerically, again, the amputation rates were higher for DCBs, but look at the p-value, 0.108. It's not clinically significant, but at least it's established that it was not linked to higher mortality. All right? And I think this was Zeller's 5-year follow-up, which was built into the original study, and which should have come out earlier, comes out later almost as a response by the industry to Katsanos' meta-analysis. Then you have the Chinese stepping in. This is Acotec, which is China's first drug-coated balloon. This is a study published in 2020, sponsored trial, okay? And it gives us some good news that all the primary endpoints were met at 6 months and 12 months, all right? The p-value is significant. And after a succession of rather unimpressive trials, this is the first time a real trial, though sponsored, comes in with significant p-values that gives some advantage to DCBs at the end of 12 months. And this is a follow-up study to the same. Again, 87 participants. And this is important because the lesion lengths here are more than or equal to 15 centimeters, 150 millimeters. And you can see that this is the same follow-up. The Chinese are able to show us that they can use their technology of paclitaxel is able to give you decent results at 6 months and at 12 months with significant p-values. Okay? This was important for Asians because we're looking at an Asian population now. But considering that the earlier was a sponsored trial, the teams from Singapore decided to weigh in with a physician-conducted trial. 2 tertiary hospitals in Singapore come out with this, the Singa-Plackley trial. This is of interest because, as I said, it's the Asian population and a physician-led trial, not sponsored by industry. It's supported by the National Medical Research Council of Singapore. And this is a dampener again. None of the primary endpoints were met. So the only, as a summary of this, the only trial to establish clear supremacy of drug-coated balloons in the BTK segment is a sponsored trial from China. Now, believe that if you might. But what happens in the wake of the Katsanos meta-analysis? Because all of us would be concerned about, is there a mortality risk to our patients? Katsanos publishes his meta-analysis in 2019. The FDA writes 3 warning letters to all physicians and calls for further investigations. A panel is set in. And subsequently, there are, in 2023, this is another meta-analysis by Sahil Parekh et al., which shows that there is no association between paclitaxel-coated exposure and risk of death. It's a significant meta-analysis, so 2,600 patients, almost 5 years follow-up. And it's now, following this, last year, that the FDA has removed its red flag from drug-coated, paclitaxel-coated balloons for its mortality signal. But the British have still not done it. The MHRA in the UK still hasn't updated this, which is do not use paclitaxel drug-coated balloons or stents in the routine treatment of patients with intermittent claudication, as the mortality risk generally outweighs the benefits. And the amputation risk was partly because of this, the slow flow phenomenon, which we've all spoken about. This was a single-center observational study, 88 FEMPOP lesions. This is not relevant, but I'll just show you why this is important, that all the slow flow groups ended up badly. okay? And they tried to find out what causes slow flow, but one of the important things was the length of the drug-coated balloon and the drug that is being given. Why does that happen? This is an animal study that tries to explain this. This is, they used impact admiral and Lutonix in a pig, okay? And they then subsequently sectioned up the pig and saw what kind of fibrinoid necrosis happened downstream in the tissues. And they found that in impact DCBs, it was in 46% versus 0 in Lutonix, okay? And that was because, and also there was higher concentration of the drug in the impact in pigs in non-target tissues. This is what it looks like. And they said that it is because of the technology they're using to coat their balloons. If it's crystalline, it has the potential of distal embolization, and also the dose. Lutonix had a low dose, and Impact Admiral had a higher dose, all right? But again, you can see that this was a study funded by Lutonix. So no surprises here. I'll move to the end very quickly. And this is what we need to carry back home, that all men and women are not created equal, and not all drug-coated balloons are created equal. A class effect cannot be anticipated. The right excipient polymer is perhaps the secret sauce. It's this paper on the pharmacokinetics of paclitaxel was established that this is the kind of particulate formation, you can see the image there, that happens following paclitaxel balloon inflation in Ranger, Lutonix, Impact. And the area under this graph is how quickly the drug is taken up and how long it stays there. It's different for all three balloons. So not all drug-coated balloons are the same. And what is needed in a drug-coated balloon? You need immediate increased drug uptake, you need extended drug retention, and you need to limit drug embolization. Anybody recognize this man? So, in the year of the moon landing, 1963, soil samples from the Easter island of Rapa Nui arrived on the desk of this 37-year-old Punjabi microbiologist in Montreal. His name was Surendranath Sehgal. Okay? Sehgal and his team isolated some microorganisms from the soil and grew them in his lab and examined the chemicals that the culture produced. And what they found was a yet unknown compound secreted by a bacterium called Streptomyces hygroscopicus that showed astonishing results. That was called rapamycin because it came from Rapa Nui, which is now known as sirolimus. So we have this man to thank, a Punjabi microbiologist, for sirolimus. And limus is a powerful immunosuppressive, an anti-migratory, and anti-inflammatory agent, most importantly. So this might have promise below the knee. It is used extensively, sirolimus or rapamycin, for suppressing the immune response in organ transplantation. And the wonderful story is that this man, Surendranath Sehgal, at the end of his life, had colon cancer, which metastasized to the liver. He was admitted in a Pittsburgh hospital where he was supposed to undergo radiofrequency ablation for the liver tumor. And in the liver unit there, while he was recovering from the RFA, the floor had transplant patients, liver transplant patients. And word soon got out that the discoverer of sirolimus was admitted there. And soon enough, people came in wheelchairs to shake his hand that, thank you for saving our lives. But anyway, sirolimus is the drug of the future below the knee. As has been established, it inhibits the smooth muscle cells most vigorously. Some of the newer balloons that have been made have sirolimus with this kind of technology. It's like sirolimus being on a sticker. So because it's on a sticker on the balloon, I mean not a sticker, but on a nano level on a sticker. So when it's conveyed to the location, which is distal, which is the below the knee segment, it doesn't get washed off the balloon. And when it is inflated, it's like a sticker on the other side, so it goes and sticks to the artery and moves within the vessel. It's a phenomenal nano encapsulation delivery, so the crystallization doesn't happen, and therefore microembolization and slow flow is not seen. What we have now is purely observational data from sirolimus. The randomized control trials, particularly below the knee, are still enrolling. Some of them are being completed. This is what it looks like. It's observational data. This is the solution observational data. This is the EXTOSI trial that Dr. Chok was speaking about. It's looking good, but remember that these are observational studies. These are not randomized controlled trials. And we're yet to see the results of randomized controlled trials specifically addressing the multifarious complexities that determine outcome. And I'll go back to Mustafa's data. This data, again, 6,800 patients, we have to deliver results better than this. At the moment, we have no evidence below the knee that can make you sit up and take notice. So drug-coated balloons, despite all the fanfare and lofty claims, have yet to decisively outshine the humble plain old balloon below the knee. Thank you very much.